start the recording? Thank you. All right, so on today's agenda, we will include introductions and announcements, an interactive discussion with Tennessee Department of Health epidemiologist Ms. Paula. Oh, and I skipped ahead. There we go. And then we'll also have case presentations and closing remarks. So I need everyone to take a moment to register with our accrediting body, the Southeast AETC. This registration is required to attain your CE. So, and it also will link you to numerous additional resources or access to those resources. So if you don't care, go ahead and take that moment to scan the QR code and do your registration. Let's see. All right, so first, some chat introductions as well as some brief announcements. So before we get started, I would like everyone to take a second to introduce themselves in the chat. You can include your name, role, organization, and if this is your first echo session with us. And Kimber, is it showing the correct screen?
You are currently on the CE for continuing education.
Okay. All right. So thank you for everyone that's putting your introductions in the chat. Go. So today we're going to talk about hepatitis C virus and organ transplant, and I'm going to hand it off to Miss Paula.
Thank you. And are you running the slides?
Yes, I'm running the slides too.
So next slide. I still see the CE page. There we go. Perfect. Hi, everyone. My name is Paula Shoup, and I'm an epidemiologist in the viral hepatitis program at the Department of Health. And we're going to be talking about hepatitis C and organ transplant. Next slide. And here's my agenda for the presentation. First, I'm going to touch on a bit of donation regulations and then do a brief overview of organ transplants, and then touch on hepatitis C and organ transplants, and then we'll go into these transplants in Tennessee. Next slide. So first, I'm going to touch on blood donation because it is treated differently regarding hepatitis C than organ transplant. So just provide a bit of a frame of reference. So blood donation in our country is regulated by the Food and Drug Administration, or FDA, and they work with the Center for Biologics Evaluation and Research, who sets all the policy regarding blood, plasma, and other biological products. And then the American Association of Blood Banks kind of helps the FDA to regulate blood banks to make sure that the process is safe for people who donate. Next slide. Okay, as far as hepatitis C and blood donation, every blood donation in our country is screened for a number of different infectious diseases, and one of those is hepatitis C. So if a donation tests positive for hepatitis C antibody, it goes through multiple rounds of supplemental testing to make sure that that donation is a true positive. If it is truly positive for hepatitis C, it's pulled from the blood supply and destroyed. The donor is then notified, and then they're counseled on the need for additional confirmatory testing, and that individual is indefinitely deferred from participating in blood or plasma donation permanently. There's a national registry where these individuals are retained. So blood and plasma centers can see if a donor is in the registry. And then, of course, if they try again under like a pseudonym or something, they'll still test positive and won't be able to participate. Every year, there's about 6.8 million people who participate in blood donation. in the United States, and they provide 13.6 million units of whole blood. About 0.5 to 1.4% of that 6.8 million test positive for hepatitis C antibody and are not allowed to participate. So it's a pretty small percentage of all the available donors who ultimately cannot participate in the process. We did not start screening for hepatitis C in the United States in our blood supply until 1990, and that testing wasn't really robust until 1992. Prior to 1992, it's estimated that about 290,000 people acquired hepatitis C through blood transfusion. So the FDA takes a really hard stance when it comes to hepatitis C. There's a lot of people who were impacted by receiving hep C through blood transfusion, and this was the era prior to a cure. So many of these people probably experienced the long-term negative outcomes from living with hepatitis C. Next slide. As far as organ donation, it's regulated completely differently. The federal agency for organs is the Health Resources and Services Administration, or HRSA, and they work with an organization called the Organ Procurement and Transplantation Network, or OPTN. And the OPTN matches individuals who need an organ with an organ once it becomes available. And HRSA contracts the Unified Network for Organ Sharing to run the OPTN for them. And UNOS is the organization that houses all of our historical organ donation information. So they own in that data, and they communicate that with jurisdictions. Next slide. A bit about organ transplants in our country. Last year, there was 46,000 organ transplants that occurred. And this came from 16,335 deceased organ donors and about 7,000 living donors. Those deceased donors can donate heart, lung, liver, kidney, so they can save a number of people with each donation. Those 7,000 living donors are primarily kidney transplants. At any given time, there's over 100,000 people waiting for an organ in our country, and it's averaged that about 17 people die every day for lack of access to an available organ that would be life-saving for them. And every 8 minutes, another person is added to that waiting list. So even though 46,000 donations occurred of the 100,000 last year, that list is constantly updating with an additional person. Next slide. So what kind of organs are people waiting for? On that top chart, we can see that 90% of the organs that people need are kidney, followed by liver and heart. And the bottom chart is the transplants that actually occurred. So is primarily kidney, followed by liver, heart, and lung. Next slide. And here we have a map of the organ donation regions in the country. The highest number of donations occur in Region 5, in purple on the West Coast, in Region 2, in gray on the East Coast, and in the Deep South in blue in Region 3. And even though those are where most of the donation or the organ transplants occur, this is not where most of the hepatitis C organ transplants are occurring. Those are actually in Region 10, Region 11, which is where Tennessee is, and in Region 3 in blue. So kind of along the Appalachian corridor is where the hep C transplants are actually occurring. Next slide. And now a bit about organ transplants and hepatitis C. The Public Health Service is kind of who advises the OPTN on how to handle hepatitis C and organ transplant. And the Public Health Service has never outright said that these transplants can't occur, but they've kind of discouraged it by calling these donations as increased risk. And prior to DAAs, hepatitis C transplants generally did not go well. The individual was less likely to have a long-term successful transplant. They're more likely to have negative impacts as far as their kidney function or going into fulminant liver failure, amongst other things, and early death. Compared to organs that were not hepatitis C positive, a positive organ went much less smoothly. So although they kind of always happened, they were not preferred compared to a non-positive organ. But once DAAs hit the market, this has been a game changer. researchers have called this profound as far as organ transplants and hepatitis C. The number of organs that have become available has dramatically increased, and a lot more people are experiencing shorter wait times by having access to these organs. In addition to DAAs really changing the scene, the opioid epidemic has played a huge role as well. Individuals that have passed away during the opioid epidemic tend to be younger, in their late 20s, early 30s. So these are organs that are younger, healthier. They're just more likely to be hepatitis C positive. So DAAs and more availability of young, healthy Hep C positive organs has really changed the way that hepatitis C organ transplants has been viewed in the country. Currently, there's about, on the national average, about 5.6% of organ donations are hepatitis C positive. And when I say hepatitis C positive, I'm referring to RNA positive. So these are viremic organs going to individuals who are antibody negative, RNA negative. So they've had no previous exposure to hepatitis C. From that map that I showed with the regions, less than half of transplant centers actually do hepatitis C organ transplant. There's still a lot of apprehension related to the previous negative outcomes prior to DAAs. Additionally, there can be hiccups as far as the insurance companies and patients getting access to DAAs in a timely manner. If somebody gets a hepatitis C organ transplant, they need to be treated immediately. They don't have time to wait months because they're immunocompromised. They can start having negative outcomes pretty quickly. So that's another hiccup. However, since 2019, even with all that, hepatitis C transplants account for about 7.5% of all transplants. And again, if you think about that percentage in comparison to only half of transplant centers are doing them, our region is doing a lot of these transplants, as well as other jurisdictions along the Appalachian corridor. Next slide. And then we'll go into organ transplants in Tennessee. I apologize, this map is so little, but on the yellow dots on the map are organ procurement organizations, and they're in Memphis and in Nashville, and they kind of facilitate all the logistics of an organ transplant once an organ becomes available. And our treatment centers are the little white dots, and they're primarily in Memphis and in Nashville. We have a couple out east and one in Chattanooga. For our HCV positivity, for our donors, we're at 9.1%. So again, the national average is 5.6. So we have more hepatitis C positive organs in the state. From 2016 to 2022, there are about 7,500 organ transplants that occurred in Tennessee, and on average, about 5.1% were Hep C positive. This trend of hepatitis C transplants is increasing over time. In 2016, we're at less than 1% of all transplants were Hep C positive, and now we're at almost 7% as of 2022. Next slide. And these are the actual facilities in our state that conduct organ transplants. And Vanderbilt is really a leader, not just in our state, but really regionally. They do a significant number of all kinds of organ transplants. Next slide. And here we have a chart of our organ transplant trends over time. You can see in 2016, we had about 5, and then in 2022, we had almost 90. So a significant increase in the number of these transplants occurring. Next slide. And here we have all transplants in light blue, and then in dark blue are our Hep C transplants. And you can see not just are our Hep C transplants increasing, but so are our overall trends. And again, this is closely related to the opioid epidemic and more organs becoming available. Next slide. There's been a lot of research that's been done into the safety and efficacy of hepatitis C organ transplant. Researchers have looked at lung, liver, kidney, all the different kinds of transplants that can occur. They've looked at different timing of when DAAs should start. Some have looked at before the transplant even occurs, some right after, some within 30 days. And they've looked at all the different factors regarding transplant. And as far as they can tell, 100% of patients achieve SVR. And generally now with DAAs, if it started soon enough, this is a really good option for patients. It dramatically cuts down on that wait time if a patient is willing to accept a hepatitis C positive organ and do a DAA round of treatment. Next slide. So since only half of organ transplants are conducting these types of transplants, advocates are pushing really hard for this to be done nationwide so they can use all the available organs and increase the pool of organs for people waiting on a transplant, increase patient access, reduce that wait time, and of course, reduce recipient mortality. If a patient can get access to an organ sooner, this is life-saving for them. Next slide. CDC is very interested in these cases. By definition, if a patient seroconverts, they're antibody negative today and they're antibody positive tomorrow, they're an acute case of hepatitis C. This is really impacting the jurisdictions that do conduct these types of transplants. Tennessee is one of 7 jurisdictions that's working with CDC to kind of assess the impact of acute hepatitis C acquired via organ transplant. They really want it to be treated differently than a case that's acquired in the community. If somebody gets hepatitis C through an organ transplant, the medical community is screening them. They're being monitored. They're getting access to treatment immediately. They're receiving education, so they know how to prevent transmission should that come up. Whereas a community case, they're probably not being screened, probably don't have access to treatment, and they could be transmitting it to other people. So the way we view it in surveillance is very different. In order to help CDC with their research, we're requesting a line list of all the organ transplants that have occurred from that list of facilities I showed a couple of lines back. We're then going to match that to our surveillance system, make sure we know about all these cases, and then assess the impact and report that back to CDC. Whatever the findings show from the research could ultimately change the way our national case definition classifies these cases. So more to come on that probably within the next year. Next slide. And that's all I have. Thank you so much for listening, and I'm happy to answer any questions.
All right. So does anybody have any questions? That was really a great presentation, Paula.
How long do you have to wait after transplant to go ahead and treat the patients?
It seems to be from the research that sooner is better, and really the question of when to start is more based on the patient, because some patients, if you start too soon, the medication may not be tolerated well as far as like their kidney function. So it kind of depends on the patient, but like sooner is better to get that viral load down.
Doing the echo pause, as Mia calls it.
Paula, are you aware, is there a limit on the viral load of those being allowed to transplant? Like, is there a cutoff?
No,
No.
from what I could see in the research, there was no cutoff. But if it was a liver transplant, they would not transplant somebody that was greater than F2.
Okay,
So that seemed to be the only restriction.
interesting. This is really incredibly interesting. Thank you.
It's fascinating. Lindsay Zimmerman and I have been watching this for years. We're like, what is going on? And to actually look into it and hear from CDC their concerns, I'm like, it is really interesting.
All right. Before we move to our case presentations, any other questions? And you can put them in the chat or you can come off mute.
Hey, Paula, it's Candy.
Hey, Candy.
Can you hear me?
Yep.
Oh, so a person can't donate blood or anything even after they go through treatment, is that right?
Correct. Yep, they're permanently deferred.
Okay. That's what I thought, so thank you.
I think it has to do with we have so many donors and they just don't need to go that route to use those samples. And you can imagine financially it'd be super prohibitive if we did have to use those samples to treat people with DAAs, whereas organs, there's so few to begin with.
All right. Thank you again, Paula. That was great. I had heard that we were doing organ transplants like that, but I did not know all of this and all that it entailed. So thank